We're going to look at differential diagnoses in terms of radiology. Um, so there are two mechanisms of soft tissue calcification. First is dystrophic, the other is metastatic. In the dystrophic case, it's basically dead or dying tissue that become calcified. And this is really because you have the pH of a dead cell, a dead tissue, it's becoming alkaline, which results in salts precipitating towards that alkaline tissue, causing the calcification. Now, in the case of a metastatic, on the other hand, it's that the patient is hypercalcemic and it results in calcium stores that are forming throughout the body. So the first example we have is Cysticerosis, and 80% of the time we'll see them in the submandibular gland, 20% in the parotid gland. If you look on YouTube or Instagram, you're going to see a lot of like people that have Cysticerosis or these stones that form in the duct. Now, the reason it happens in the submandibular over the parotid is the parotid gland or the Stenson duct that's going to the parotid. In the case of Stenson, it's a much shorter duct itself, so it's easier for the fluid to actually leave out. While if we're looking at Wharton's gland that's in the submandibular, this gland, this duct itself, sorry, is going to have to first move its way up against gravity, and then from there it goes around the mylohyoid muscle to finally eject the saliva outside of the submandibular gland. Well, what that means is it's a longer path. So as a result, calcifications can stay there and slowly form these kind of hard masses. So an example is a chronic obstructive cellulodentis, or dentis, which is basically when you have a salivary duct that is blocked by a cyalolith. And this is going to cause a lot of pain for the patient. So anytime you eat, you're going to have more saliva being produced. And as a result, if the patient is eating, they're going to end up having this pain because saliva is going to want to make its way around the cyalolith. And it's going to be very uncomfortable until that cyalolith is removed. You can have a submandibular stone, which is solitary and it's going to have a smooth outline, and that's kind of what's pictured right here. You can have parotid cyaloliths versus tonsillus, and I found this very confusing, so I'm going to try and simplify it. So if we're looking at a parotid cyalolith, it's going to be basically over the soft tissue and partially over the ramus, which means that if you see something that's kind of like above the mandibular canal or kind of on the ramus back here, it's going to be a parotid cyalolith. Another way to think about this, our parotid gland sits right around here. It's like right on that ramus. So if you see something right in the location where the parotid is, it's probably a parotid cyalolith. Now, a tonsillith, on the other hand, kind of think about the location. Your tonsils are going to be basically around your oral pharynx, and anytime you're going to have some infection, it's going to want to send it down into your lymph nodes. So if we're looking at this, we can expect that the tonsillith is going to be below the mandibular canal. So right here is our mandibular canal, and we see these kind of like individual specks right here, and these are going to be your tonsilliths. Now, rhinoliths and antroliths. Rhinoliths can be endogenous in origin. It can also be exogenous. If you think of rhino, think of nose. So your endogenous ones are going to be anything that's like a foreign body reaction with granulomatous and necrotic tissue. Or you can have exogenous forms. Basically, you shove something up your nose. So this is going to be common in kids. Your antrolith, on the other hand, this is a calcified mass within the maxillary sinus. So if we look at this image right here, we see the maxillary sinus, same thing, where we have this kind of mass that sits there. Most are going to be small and asymptomatic. The larger ones may present as sinusitis with symptoms like pain and discharge. Typical features are going to be that they're unilateral nasal obstruction. So in the case of this, you see that it's only on one side. It's going to cause pain, epistaxis, epi, epitaxis, fetid rhinorrhea, postnasal drip. The extrinsic form is going to be a foreign body in the sinus. This could be a tooth that made it into the sinus, the maxillary sinus. It could be really anything. If it's intrinsics, on the other hand, it could be a stagnant mucus. It could be a fungal bulb. Phleboliths, I can't say that word, I'm sorry. Basically, it's calcified thrombi within veins and venules. It's going to be in the head and neck, most often associated with a hemangioma. So if we look at this image right here, we see the erythema multiforme. And the interesting thing is, if we look, it has this bullseye pattern right here, where you have the center right there, and then the target around it. If you look for the target symbol, basically, it's erythema multiforme or a Phlebolith. Okay, Monckeberg's medial calcinosis, and that's kind of highlighted by these arrows right here. It's basically an atherosclerosis where calcium deposits are found in the middle layer of the walls of arterioles. So this is going to be in the tunica media. So calcium deposits hang out in the tunica media, and it's more common with hypoparathyroidism and chronic renal failure. Because if we think about hypoparathyroidism, what that means is you have increased parathyroid hormone, but you also have increased calcium. So having increased calcium means that in this case, we're going to have increased calcium deposits in the body. Chronic renal failure is the same thing. Your kidneys are going to help excrete your calcium. Well, when your kidneys are not working, we're going to have more calcium in the body, and so that means that you're going to have more potential calcium deposits. In terms of the radiograph, you're going to see a tram track or pep stem calcification. So if we look at this, it kind of looks like tram tracks apparently. Now, if we look at a calcified atherosclerotic plaque, what's unique about this is you're going to typically find it right at that bifurcation of the common carotid, where the common carotid splits into the internal and external common carotid around C3 and C4. And this is going to be above or below the hyoid bone. We're going to see that radiographically it's irregular verticolinear opacities. So that's kind of where these arrows are pointing right here, here. Eagle syndrome. This has nothing to do with the football team. It's associated with post-tonsillectomy. So basically, patient goes in, they have their tonsils taken out. Afterwards, they're going to have throat pain, dysphagia. It's going to feel like there's something in their throat. And when they yawn, there's going to be pain because they're compressing on the cranial nerve 12. And this could cause recurrent otitis media, which basically means earaches. You can have carotid artery syndrome, which is associated with also post-tonsillectomy. Basically, the patient has throat pain, dysphagia, foreign body sensation, pain on yawning. Again, it's related to compression of cranial nerve 12. You can have recurrent earaches. I'm sorry, I just realized there's a mistake here. This all right here does not apply. I'm so sorry about that. Ignore what I just said. So in terms of carotid artery syndrome, this is no history of tonsillectomy. Eagle syndrome is tonsillectomy. You have carotidemia, and the interesting thing about carotid artery syndrome is that if you're turning your head and it's compressing on the external carotid, you're going to have pain when you turn your head. It's going to lead to otalgia, vertigo, tinnitus, and otitis media. Now, if you turn your head and it's dealing with the internal carotid, it's going to cause syncope and pressure on the baroreceptor. Now, if we're looking at the laryngeal canal, we have the tritigious cartilage. It's about 7 to 9 millimeters. It's bilateral thyrohyoid membranes, and it's going to sit below the greater cornu of the hyoid and above the superior cornu of the thyroid, and that's this cartilage right here. Then we can have intraosseous choristoma, which is this guy back here. Intraoral, which means inside the mouth. Osseous means bone. And choristoma, which means benign tumor. So if you put that all together, what we mean is a benign bone producing neoplasm. And typically this is going to show up in the back of the tongue. If you were to push it, thinking about what it is, it's a benign bone producing neoplasia, which means that it's going to be pretty hard or firm to touch. Since it's going to be bone, it's going to be asymptomatic. It's also going to mean that it's not going to be moving because it's just hanging out there, so it's going to be a sessile mass. Of course, since it's bone, radiographically, it's going to appear as a radio-opaque nodule, and it's going to have a cortical rim and internal cancellous bone. Now, if we look at miliary osteoma, and these are going to be multiple small, round, radio-opaque with radiolucent centers. Kind of think of a donut. So if we look back here, we see this exact representation. It's kind of hard to see that it's donut shaped, but it's circular, and in the center it's kind of empty. Myocytitis ossificans has two groups. It has traumatica and progressiva. Traumatica, what that is it's localized, appears following the trauma. Treatment is going to be surgery. You want to make sure that you wait until the calcification is done doing its job. And then once it's done doing its job and you see that there's no additional growth, so you're going to take radiographs over time to see that it's not continuing to grow. At that point, you surgically remove it. If you try to remove the calcification while it's continuing to grow, what will happen is it will kind of agitate that calcification or that process of calcification, and the result is much worse, and the patient's going to be much more upset. Progressiva, on the other hand, is more rare. This is the one, you know, they say anytime it's rare, it's probably going to kill you. In this case, it's true, because these calcifications go towards the heart as well as the diaphragm. And so if the diaphragm ossifies, that basically means you're dead. If the heart ossifies, it's kind of the same thing. You're dead. Cysticerosis Cellulosae. Basically, it's a tapeworm that lives in your intestines. And while it's alive and the larvae are alive, it's going to be parasitic. And radiographically, you cannot see this because these worms are like really weird in the sense that they can evade the host immune response. But once they die, for some reason, the host immunity is going to attack them. And then radiographically, you see that these larvae are parallel to the bone, not the bone, sorry, the muscle. So that's why they have kind of like these patterns like you see right here. And these are the last three things. So CREST syndrome is ulcerating calcinotic masses. So if we look at it, these right here, these are just a bunch of nasty kind of calcinotic masses. Dermatomyositis is calcinosis of muscle and subcutaneous tissues. So if we look at this, we have basically calcium deposits that are basically stones in the muscle, and they're hanging out there. They look really nasty. And then you have calcifications and metastasis, and they can appear as soft tissue and extraosseous or periosseum metastases. So we see it right here as an example. Well, I hope you guys liked the video. If you have any questions, comments, leave them below. Please subscribe to my channel, and if you can, give me a like.